A very pleasant good afternoon to all of our viewers and friends. Those of you who are listening on Second Advent Radio, we welcome you just the same. This is Let's Talk. Let's Talk is a program sponsored by the Seventh-day Adventist Church South Leeward Conference. And I am Pastor Greene, the president of the conference. We take this time each week to talk to issues, and we seek to deal with very challenging issues in very varying aspects of life. Just to let you know that next week we begin a brand new series. We're going to be talking about perspectives of young Adventist professionals. What do they think about the Adventist Church? So you want to be in on that one. For today, however, we are finishing our series on aging. We have shared for the last 3 weeks some wonderful insights about aging, and I want to just express profound appreciation to all of my friends. I was on Nevis last week, and so many of the folks there indicated that the program has been a tremendous blessing to them. This afternoon, as we finish up, we're dealing with the issue of dementia, and so many folks have been saying, I can't wait to hear that one. I can't wait to hear that one. Well, we're here, and we have a very special guest with us. She is not a stranger to Let's Talk. She did grace us with her presence some time back, and I am just delighted to welcome again Dr. Sandra Reed with us this afternoon. She is a psychiatrist. She has a tremendous experience in this area. She is an influential individual at the University of the West Indies there in Trinidad. We are delighted to have you with us. Dr. Reed is also a woman of God. In fact, she is the first elder of the church in the University of the Southern Caribbean. We are delighted to have you with us, Dr. Reed. Good afternoon.
Thank you. Good afternoon, Dr. Greene. It is my pleasure to be here, and thank you for your warm welcome.
Wonderful. We are going to invite our listeners and viewers to take the moment for us just to talk to God before we begin this afternoon's program, and then we will go right into our discussion. Father, we thank you for the opportunity and privilege to be able to share. We have for the last 3 weeks been discussing this matter of aging and spirituality, and we come to our final presentation in this area. We ask that you will guide the discussion, be with our guests, and grant that the information she shares will prove meaningful. Thank you again for hearing and answering. Be with us. It's stormy in my area of the Caribbean, and we pray that you will grant that we will not have any internet issues, that everything will go well. We give it all to you, and thank you in Jesus' name. Amen.
Amen.
Wonderful. So, Dr. Reed, it's a delight to have you with us this afternoon. As indicated, we have been dealing with this matter of aging, and we're talking about aging and spirituality, its impact. Is there a relationship between aging and spirituality? How does aging impact spirituality? And we decided, well, from the very onset, that we had to touch on the area of dementia. So one of the most feared effects of aging is the onset of dementia. And you're going to explain for us some terminologies. I'll get there in a minute. It is a significant challenge to see someone who has or once was a spiritual leader and who slowly progressed to the maybe I shouldn't use the word progress, but anyway, to the point of not remembering faces, or even to the point of questioning the church and its importance. Why does it happen? Can it be helped? Is it at all related to one's spirituality? These are questions that many have asked over the years. On today's Let's Talk, we want to explore this topic with the aim of providing awareness and understanding. We are not here to answer every single question that everybody has, but we want to be able to provide awareness and understanding. So, Dr. Reed, you are just about the best person I can find to help us with this. And we want to begin with terminologies. We sometimes use the terms dementia and Alzheimer's interchangeably. I've heard that a lot, but my understanding is that they are in fact not one and the same. Can you explain the difference for us?
Okay, so thanks again, Dr. Greene. Let me start my answer by introducing another term. And the term I want to introduce is cognitive function. Our cognitive function is our ability to think, to reason, to remember, to plan, to focus, to concentrate, all of those functions that are associated with the cerebral hemispheres of our brain. Dementia is the medical term that we use to describe impairment in one's cognitive function to the extent that it affects daily living. So I want to emphasize that point, to the extent that it affects daily living, because we would know, I mean, myself included, when we're getting down in age, cognitive function is impaired naturally with aging. The memory is not as sharp as it used to be. Sometimes the focus and the concentration are not as good as they used to be. But we use the term dementia only when we are describing the impairment to the extent that it affects your daily living. So it's a problem. Now, a doctor can diagnose dementia because you have someone who can't remember, they're not thinking clearly, they're making poor decisions because their judgment is impaired and it's affecting their life. But dementia, as you said, is not the same as Alzheimer's, because dementia is a syndrome. It is a syndrome that says something is wrong. But the next step must be to identify the cause of that dementia. Think of it like fever. When you have a fever, you know you're sick. But fever is not an illness per se. Something is causing the fever. Fever, you either have a pneumonia or urinary tract infection. In the same manner, you can have a dementia, but something will be causing it. The commonest illness to cause dementia is Alzheimer's disease. Almost 2/3 of cases of dementia are due to Alzheimer's. So Alzheimer's disease is a type of dementia.
Okay, so it's a type of dementia. All
Yes.
right. It's therefore correct to say, in fact, you use the term syndrome.
Syndrome.
If I listened correctly. So you said that dementia is a syndrome, and Alzheimer's is just one of those things. So dementia then is an umbrella term to include several conditions. So let me see if I have this right. If I have Alzheimer's, I am suffering from dementia, but if I have dementia, I do not necessarily have Alzheimer's. Is that correct?
That's perfectly correct. That's it.
Okay, wonderful. Now that I am learning as I go along, what are the examples of dementia? Alzheimer's is one that a lot of people are familiar with, but what are some of the other common ones in our world today?
Okay, all right. So I mentioned before that Alzheimer's would account for about 2/3 of the cases of dementia. But what we really need to keep our eyes on is the second commonest form, which we call vascular dementia or multi-infarct dementia. Why I say we need to keep our eyes on that? In the Caribbean, we have a high prevalence of the lifestyle diseases, diabetes and hypertension. Diabetes and hypertension affect the blood vessels. I mean, we might have heard about atherosclerotic plaques that you get that narrow the blood vessels, or in diabetes, the elasticity of the blood vessels changes and they become narrower. And once your blood vessels narrow, then the organs supplied by these particular vessels become affected. So the blood vessels to the brain can become affected by changes due to poorly controlled diabetes and out of control hypertension. And if those vessels become blocked or they rupture, there is damage to the particular area of the brain that is supplied by the vessels. And when these areas are in the cerebral cortex, and the cerebral cortex is the main part of the brain, those two big hemispheres that we see when we see pictures of the brain. When those become blocked, we call that a stroke. People are common with a stroke, familiar with a stroke. But what a lot of people do not realize is that you can have a temporary blockage of these blood vessels, and they cause mini strokes or TIAs, transient ischemic attacks. And when you have transient ischemic attacks with damage to the brain, you may not recognize what is going on because these are relatively mild symptoms. And because the blockage is temporary, they disappear after a few minutes, or they might last about a day for the longest. And these temporary blockages can damage the brain to the extent that if they occur frequently enough, you end up with a multi-infarct dementia or a vascular dementia. All right, I hope that's clear.
I almost want you to go over some aspect of that. I'm here kind of transfixed by what you're saying. But just in case there is somebody who is a little slower than I am, if you can just go that, because you're saying that we as we move along from day to day, things happen that can impact us. I think I'm hearing you say that. Just go it over one more time for us, please.
Right. Okay. So if you happen to be diabetic or hypertensive, and these disorders are not well controlled, so your blood sugar is high very frequently, your blood pressure is high very frequently, you actually damage your blood vessels. And we know about all the damage that could occur, let's say from diabetes. The eyes can be damaged, the kidneys can be damaged, the peripheral nerves and so on, right? But the brain can also be damaged. And I'm saying that sometimes the damage to the blood vessels causes a temporary blockage that actually damages the brain. And the symptoms of this, we call it a TIA. So let me give an example of symptoms of a TIA. TIA is a transient ischemic attack or a mini stroke. You might get weakness or paralysis of one side of the body, the arm or the leg. You may feel the pins and needles and it doesn't go away. Speech may become slurred. So sometimes you hear a patient would say, all of a sudden I couldn't speak. My speech became very slurred, or the relatives might say his speech became slurred, but then it cleared up after a few hours. You may experience even blindness in one eye, or severe headache with no very apparent cause. These are symptoms of a TIA. But because they last short, people tend to dismiss them. But if they occur repeatedly, you can damage the brain to the extent that you can develop a dementia. And that type of dementia is called a multi-infarct dementia or vascular dementia. And we are seeing more and more of this type of dementia.
Now, I mean, because we're also talking about aging in all of this thing, and you indicated that individuals who suffer from high blood pressure and diabetes, if those are not managed well, there are some individuals who, for whatever reason, just don't give any attention to even knowing their numbers. They have been living, they're not even aware that they are hypertensive, for example. So we're saying that there is a lot of danger in this, more than, I mean, I never really, to be honest with you, this is something that I'm learning now, that relationship that you just explained there. So that's another reason why people must give attention to their status, knowing and managing their high blood pressure and controlling their sugar levels, etc. Very insightful.
Yes.
It's almost frightening.
Yes, exactly, because lifestyle disorders are disorders we can control. So it means that there is a proportion of persons with dementia where that dementia is actually preventable. So that's important. Now, I want to mention two other types of dementia because I see them in practice, and I think they're relevant, even though they may not be as common as Alzheimer's and the vascular dementia. The third one I want to mention pseudo dementia. Now, pseudo, we know that prefix pseudo means false.
Yes.
So pseudo dementia is actually a false dementia, but it looks like dementia. And this occurs in elderly persons who are depressed, right? So we know the symptoms of depression: sadness, crying, you can't sleep, you can't eat, you feel suicidal, and so on. But as you get older, in those 60 and over 60, you can become depressed. And your most prominent symptoms are not the sadness and the crying, but they are a disturbance in your cognitive function. And remember, we said dementia is impairment in your cognitive function. So when you present to the doctor, and they see cognitive impairment, they ask you your age and you're 72, they immediately going to think, oh, dementia, Alzheimer's. So you need to have a proper assessment. And that proper assessment may actually reveal that you suffer from depression. Why is this important? It's important because Alzheimer's is not reversible. Vascular dementia is not reversible. But a pseudo dementia due to depression, if you treat the depression, the cognitive impairment is reversible. So it's important, very, very important to be adequately assessed if an elderly person develops cognitive symptoms. Now, the other one I want to mention is similar in that its importance has to do with its reversibility. And it's important among us, the Seventh-day Adventist population, and others who might be listening who do not eat meat. All right. So we have, I believe, a relatively high prevalence of vegetarians and vegans in our population. And vitamin B12 is one of those vitamins that you can become deficient in if you are not a meat eater, unless you take your supplements. Mm-hmm. And vitamin B12 deficiency can also resemble dementia. It can look like a dementia. And it's reversed because once you supplement your vitamin B12, the cognitive impairment goes away.
Dr. Reed, you are sharing some very important principles there, and I know that our listeners are very grateful for these. I want to just go back to the pseudo dementia element that you mentioned a short while ago. And you indicated that depression can lead to this.
Yes.
I had a very good friend, I could say, who committed suicide towards the end of his work life. A very outstanding individual, and to my knowledge, a very solid Christian person. So I was really challenged to hear that. Now, my understanding, and I'm not going to make any judgment statements, but my understanding is that he had begun to see signs of cognitive decline and was not able to accept these things, and he ended his life. We are talking about spirituality and aging. This whole program is about spirituality and aging. And so, if an individual, now that may be a very, very small percentage of persons who may do something like that. But when an individual gets to the point where he or she realizes that the body is not responding the way they're accustomed to, and they slip into depression, or they slip into not being able to accept this reality, and they're tempted to lose their life. How does this fit with an individual who is supposed to be spiritually grounded?
Yeah. I can see how that can be a very challenging concept, because as Christians, I always say a depressed Christian or a discouraged Christian is an oxymoron, because as Christians, we really should have that hope that would not put us in that place. But we know that we are all on a journey, and we all have not arrived where we are supposed to be. Now, dementia, because the situation you just described, of course, we only supposing here, right? We don't know any details, and so it is possible that an individual can develop Alzheimer's disease, and the emotional response to the Alzheimer's would be a depression. That's different from a pseudo dementia, because there you have a true dementia, real dementia, Alzheimer's, and the person is responding with depression. That occurs commonly. As a matter of fact, there is a symptom that we see in persons with Alzheimer's that we call the catastrophic reaction. And that is when the individual recognizes that they can't do what they used to do. They have that awareness that the memory is failing, and they have the awareness that they can't drive properly anymore because they get disoriented. And that causes so much frustration that they react in an angry, aggressive manner that we call the catastrophic reaction. right? So we know that in the early part of the illness, people do respond, and understandably so, especially if you're a bright, functional person, a pastor who has been able to help thousands of people in your career, and all of a sudden you realize you can't function the way you used to function. I think that depression is, I would say, a reasonable response. Now, I would go so far to say as this is where faith has to take us through. That even though we're going through this totally destructive experience, we have to trust God that he knows what he's doing. And that is faith on the part of the individual with the dementia, but faith also on the part of the loved ones. Because it's, you said it at the introduction, you said it at the beginning, it's extremely traumatizing to watch your loved one literally disintegrate cognitively in front of your eyes. And the only thing that you could do is trust God. Now, as dementia progresses, as Alzheimer's progresses, the patient, the person with the Alzheimer's, they become less and less aware of surroundings and self, and because they are unable to engage cognitively. I can't say that I know for sure how they experience that advanced part of the illness, but my guess would be that they are so ill, so unaware that it no longer affects them. The ones who are affected now as the illness really becomes severe are the loved ones. So they too have to trust in God and hold on to God and recognize that, hey, God is allowing this for a reason.
Yes, indeed. We are incidentally studying this quarter, crucibles. There are challenging circumstances that we will find ourselves in from time to time.
Yes.
And if we don't learn to trust God in difficult times, I'm just here thinking that, orientation to life is also important, because if a parent never allows his or her child to experience denial or hardship, then when something difficult really comes upon that individual, they may not just know how to deal with it. So it's important, and there are lots of associations that one can make. But let's go on, because I don't want our time to run out and we don't get through some of these very important things. Now, on the matter of aging, and it appears that some people are concerned that if when I get older, these are likelihoods to happen, then maybe, I was talking to a lady a few weeks ago while I was in Trinidad at the union session, and she said to me, old age is a challenge, but then again, we have a choice. We can just die. We don't want to make any suggestions to that effect at all. Not at all. Now, I hear a lot about Parkinson's disease. How does this relate to dementia, to Alzheimer's, to cognitive decline?
Okay, all right. So Parkinson's disease is another brain disorder of the elderly. It primarily affects another part of the brain, the basal ganglia. That part of the brain is responsible for movement. So Parkinson's disease does not begin with a dementia. It begins as a movement disorder. Again, it occurs, as I said, mainly in the persons over 60. It's a disease of the elderly. Very few cases occur in younger persons, but it causes movement symptoms. The commonest symptom that we would be familiar with would be tremors. Tremors of the hands, tremors of the arms, the legs, even the head and the jaw. Persons with Parkinson's may develop tremors. Now, let me just stick a pin right here. As you get older, you also get tremors, and these are called essential tremors. I don't know why they chose to call it essential tremors, because they're not essential, but they call essential tremors, and that's considered a normal part of aging. The difference between the tremors of Parkinson's disease and essential tremors is that the tremors of Parkinson's disease occur even when the muscles are at rest. An older person who just has tremors, they rest the hand, and so the tremors go away. But with Parkinson's, the tremors occur even when the muscles are at rest, and it's accompanied by a slowing down. If you watch somebody who has Parkinson's, they move very slowly. It's called bradykinesia, a slowness of movement, and they become very stiff. The muscles they describe as lead pipe rigidity. Now, when you think of a lead pipe, you can't bend it. So even if an individual tries to bend the arm, there is that rigidity and stiffness to the point where, as the illness advances, the person becomes hunched over and they lean forward and they're shuffling. So it's really a motor disorder, movement disorder. Now, as Parkinson's advances, the brain becomes affected as well. And you can get the same symptoms of cognitive impairment. And this is called a Parkinson's dementia, right? So dementia is one of the consequences of advanced Parkinson's.
Okay, now you did indicate earlier that Alzheimer's is not reversible. Is Parkinson's reversible?
No, it isn't. Most of these brain disorders are not, because they represent actual death of the brain cells. The neurons in the brain, they die. And this is not at all reversible. Now, Parkinson's disease can be treated with medication. So you can control the symptoms. And that is well done for most of the illness. As it advances, you tend to be a little less responsive to the medication. Mm-hmm. But no, I have to be careful what I say here. I was about to say, unlike Alzheimer's, you can use medication with good clinical effect in Parkinson's disease. The reason why I hesitate, there is medication for Alzheimer's disease, all right? These anticholinesterase inhibitors. The idea is you give the person drugs that will prevent the breakdown of certain neurochemicals that are destroyed in Alzheimer's disease. I have to again be cautious as I speak. I'm a psychiatrist. I do treat people with Alzheimer's disease. And I have found that the medication is not as effective as the distributors and manufacturers would want you to believe. All right. So I would prescribe it only if I diagnose the illness very early. But most times people come for medical attention later on in the disease. And there are other things that one can do, lifestyle things. But there is nothing, no medication, no lifestyle change that reverses the Alzheimer's, as we said before. What you can aim to do is to slow down its progression, but you cannot reverse what has already been lost.
So when we hear of all of these ads that people make you believe this is good for Alzheimer's, this is good for that, a lot of them are not truthful at all then.
Well, no, I wouldn't I wouldn't go so far as to say not truthful. That sounds a little too dishonest, right? But if persons are led to believe that Alzheimer's can be treated, that's a misleading. It's a misperception. So the drugs aim to slow down the progression, right? And as I said, there are instances when that slowing down does happen, but usually it's when you put the person on the medication early in the illness, not at the advanced stages.
Okay, now I want to just jump back to Parkinson's disease a minute.
Yeah.
Because you mentioned essential tremors. I was reading something the other day, and I was a little surprised to see that there is a significant number of individuals who are impacted by tremors, and then there is something called shaky hands. So if an individual realizes that they're having discomforts with the shaky hand thing, should they become concerned that, oh, maybe I'm getting Parkinson's disease? It may be an indication that they need to get themselves checked out. What is your suggestion here?
All right. So that's why I made sure to mention that the tremors can occur as a natural part of aging. We can't do anything about that. There's no treatment for that. You can't reverse it. We just accept. The Bible had some reference to that. It talks about the shaky hands. So that we can't do anything about. Now, of course, the concern would be is this Parkinson's? And if you want to absolutely get a clearance, you go get a physical checkup, let the doctor reassure you that it's not. But if you kind of want to try to figure it out yourself, the distinguishing things you look for, as I mentioned before, if you are shaking, even when your muscles are at rest, you're not using your hands, you're not pointing to anything, you're not doing anything like that, but you still have the tremor, then you definitely should get that checked out. And if your tremor occurs with some of the other symptoms of Parkinson's, like the slowing down and the feeling very stiff, and the facial expression becomes very dull and blunt, you don't see the aliveness of emotions in the face, then again, you definitely want to check out to see whether you have an early diagnosis of Parkinson's. The earlier the diagnosis, the earlier you start treatment, the better the outcome.
I can see why this question that somebody just submitted is relevant at this time. So let me go ahead and ask it. Are there diseases that should be expected? Are these, I'm supposing they're asking, diseases that should be expected as we age? And then, can age be toxic? Very interesting question.
Oh gosh. Well, the toxicity of age is that it's a risk factor for all of these illnesses we're talking about. So if someone were to ask me, what is the biggest risk factor for Alzheimer's? Aging. What's the biggest risk factor for Parkinson's? Aging. So in that regard, we are at increased risk as we age. Now, whether these are illnesses that we should look out for, I would say no, not necessarily, because these are not very prevalent illnesses, right? Dementia affects about what, 2% of persons over age of 60, vascular dementia less than that, Parkinson's less than that. So they are not common disorders. So it's not as if we should be looking out for them, right? But we still want to be aware, because if they do occur, early treatment again is better. Well, for Parkinson's, Alzheimer's, it really doesn't matter. No, you can't use the medication. So yeah, early diagnosis is better, right? But we don't want to become too paranoid or obsessed about it, because they are not common disorders, not half as common as diabetes and hypertension.
It just seems to me as though, I don't know if maybe because of where I sit, but so many persons indicate to me, oh, my loved one is suffering from this dementia. But the good side of that too, I just came back from a trip from Nevis. I spoke to a lady who's 99. I hadn't seen her for about 3 or 4 years. I walked into her room and I said, do you recognize this voice? She said, take off your mask, let me see. And she said, oh, Pastor Greene, that's you.
Yes. Yes.
You know, that was very encouraging,
yes.
Very collective. At 99, I thought, oh, this is awesome.
Yes.
So my next question is you mentioned that vegans and vegetarians need to ensure, this is something that should be common knowledge now, that the vitamin B12 supplement is a necessity. Although there are some persons who go out on a limb, unfortunately, and say they're not going to take any supplement. But is my lifestyle, I mean, is there value to being a vegetarian, a health advocate? How does that impact my age in general?
Yeah, okay. So it doesn't impact aging, as far as I know. A healthy lifestyle is, the diet of a healthy lifestyle is usually a vegetarian diet. You could look at any condition, almost any chronic condition, and when they talk about the things that influence the prognosis in a positive way, you're going to find diet. And the avoidance of meat, especially red meat, is always going to be there. And if you look at what is associated with a negative prognosis, you're going to find the meat eating there. So a healthier lifestyle makes for better health in general. Now we're talking dementia and we're talking the brain diseases. Remember when I said earlier that we really do need to talk about vascular dementia, because vascular dementia is a consequence of lifestyle illnesses. So if we go back, let's go backwards. Vascular dementia is caused by poorly controlled hypertension and diabetes. Hypertension and diabetes are caused in part by a poor diet. A vegetarian diet or a vegan diet reduces the risk of diabetes and hypertension. And if you are hypertensive or diabetic, improves your outcome. So if we follow it through, it means that you reduce your risk of a vascular dementia if you eat healthily. And to eat healthily is to be a vegetarian or vegan, most healthily.
Okay, wonderful. Now, let me just throw in this other question, since somebody did ask this when we were talking about the relationship that can exist between the not managing your diabetes and your hypertension carefully. Should diabetics and anyone with advanced blood pressure levels avoid all the sugary tropical fruits in the Caribbean? This is one of our listeners asking this question. So are they asking, so no mangoes and sugar apples, etc.? I mean, that's a little beyond what we're talking about, but go ahead.
Yeah. So that's for your nutritionist and your dietitian, and those are not my areas of expertise, but I can still speak. Sometimes people think that to be on a diabetic diet is to have the most bland, most unenjoyable diet in the world, but that is not so. If you consult with a dietitian or a nutritionist, they can recommend your caloric intake, and that recommendation can include fruit, even the sugary fruit. What we want to avoid by all means is intemperance. So when it's mango season and the mangoes are just there around you and you are tempted to sit and eat 2-3 mangoes at a time, that's bad. It's bad for, well, it's bad for a person with diabetes, it's bad for a person with pre-diabetes, and it's not good practice for somebody who does not have diabetes, because we want temperance in all things. So it's not so much that we want you to exclude all of the nice tropical sweet fruit, but it's all about balance, and it's all about planning your diet in such a way that your overall caloric intake is not excessive. So I would suggest meeting with a dietitian or nutritionist so that the person can learn how to incorporate the fruit in the diet in a healthy way.
Well said. Now, I have this thought, this philosophy, maybe not, but I like science. I remember when I was doing my A-levels in the Caribbean, we still do advanced levels. At least when I was in school, we used to do external Cambridge A-levels, you know. And the project I did in my chemistry assignment was the wonderful world of plastics. In those days, plastic was a great thing. Now we're hearing of all of these effects, microplastics and what they do to us, etc. I have a very good friend who's a polymer scientist, and he and I talk from time to time. You know, we talk about these things. A lot of our water is transported through PVC pipes, etc. To what extent does environment impact the conditions that we are experiencing these days? Every now and then scientists come up with some wonderful discovery. There was a time when asbestos was the best thing in the world, and then later on we discovered that, oh, it's carcinogenic, etc. and so on. Are we all impacted? I mean, you know, there is all of this cognitive decline. Is it possible? I don't know, I'm just asking, is it possible that some of the levels of cognitive decline that we're seeing may be related to the environment?
Okay. I don't know how to answer that question, because I admit I'd have to go back and do some more recent reading as to what the research literature says. I know that aluminum got a bad rap at a point in time as it relates to dementia. And then the studies came out that no, aluminum does not increase the risk of dementia. There's the whole issue of lead and cognitive function. I think that one still holds up. And most people know that you want to, lead is a toxic substance that you don't want that exposure to. With regard to Alzheimer's specifically, apart from aluminum and lead, there's nothing that comes to my mind right now, but I want to share something. And this is not to scare people. You know, sometimes we share things on programs like these and people listen and they hook into it, and it causes a lot of unnecessary trauma. But it is something that I'm interested in because it has affected one of my own family members. There is a study that is ongoing now between researchers at the University of the West Indies and some US scientists that speaks about soursop and dementia, or soursop and brain disease. A lot of work has been done in Haiti, and they are doing work now in Trinidad that speaks about both the fruit and the leaf as a possible risk factor, so that we count that as an environmental factor that can increase the risk of dementia. The evidence so far seems pretty solid, but again, it's a very low proportion of persons. And I know that soursop is one of our commonly used herbs, especially for insomnia. For example, people, you make their soursop tea and they drink that if they're experiencing insomnia, and it does help with sleep and all of that. And while I am a strong advocate for the use of natural remedies, especially the ones that have been shown by research to be effective, I think that sometimes we do have to be careful about the toxicities or possible toxicities of these as well. So I'm just mentioning soursop, not to scare people, not to tell people, stop drinking your soursop leaf tea, but to become aware that if you notice anything that's happening, or maybe if you drink soursop every night, cut back on your soursop a little bit, right? That's the soursop leaf tea. So that's another environmental factor that came to my awareness pretty recently. Now, the other environmental factors that might increase the risk of dementia are the ones that we spoke about before, that increase the risk of the lifestyle diseases, and by extension, the risk of dementia. So we can add to the list, apart from diet, you want to exercise regularly. That's an environmental factor that works in a positive way. So you exercise, you have a regular schedule of exercise, at least 150 minutes per week, every week, and you reduce your risk of lifestyle diseases and therefore vascular dementia. And if you happen to be a smoker, you want to stop that, because smoking narrows the blood vessels. And again, you increase your risk of lifestyle diseases and vascular dementia.
Wonderful indeed. Now, let's go back to Alzheimer's a bit. Several times this afternoon, you mentioned it's not reversible. It's one of the major conditions that impact people who are suffering with dementia, etc. But why is it important that we consider what you're saying? I'm in my 50s. I'm very interested, but what about the 20 or 30-year-old who is listening? Is this something that should concern him as well, or her as well? Some people say, oh, that's an old people topic, I don't need to know about it. Why is this important for the younger person?
Okay. Dr. Greene, this is one time I wish we were face-to-face, because I would have taken that question and thrown it back out to the audience, especially the young people in the audience. I would say to them, considering what we have been saying over and over again in this session so far, what is the answer to that question? And I think the answer would be very clear, right? Lifestyle diseases. Talking about lifestyle diseases again. Now, the person who is young would say, okay, Alzheimer's is a disease of the elderly, and that's very true. It doesn't occur until persons are over 60. There are very, very few rare types of Alzheimer's that begin earlier, right? We call them the pre-senile dementias. And there isn't anything I could do about it. Aging is the risk factor. Yeah, I could eat healthily and so on, but it's not relevant to me. And I would accept that. But when we're talking about vascular dementia, and we look at what is happening in the Caribbean and in the world, and we are seeing increasing rates of things like prediabetes, diabetes, hypertension, and certainly obesity among our younger persons. All of those are indicators that these persons are at higher risk of hypertension and diabetes. And as we've been saying over and over and over again, if you have those lifestyle illnesses, your risk of cognitive effect, negative cognitive effect, negative cognitive impact is greater. And that is preventable. If you are destined to develop Alzheimer's, and we don't know why, there is a genetic contribution, but there's nothing that you can really do to prevent that. But you are not destined to develop vascular dementia. That is one that you have control over. That is one that you can prevent completely if from a very young age you look at your lifestyle habits and you establish these principles that the Adventist Church is known for and that the science is now catching up with, the importance of healthy nutrition and diet, which usually translates to a vegetarian diet, the importance of regular exercise, even from your youth, etc., etc. So it is relevant because you could prevent the possibility of a vascular dementia.
Now you may have said this before. I'm not sure. I may have missed it. But as you see people, and even maybe not in your own personal practice, but the information that you're exposed to, in terms of a percentage or a proportion of individuals suffering with dementia, how do you compare the pseudo dementia, those elements that are related to lifestyle versus the dementia that cannot be reversed?
Okay, I don't have statistics. But I can tell you that vascular dementia is on the increase, right? So we are generally seeing more persons diagnosed with dementia. Now that could be due to several reasons. So unless somebody does the research, we wouldn't know for sure. It could be that people are becoming more aware, so they are seeking help more. And it actually does not represent any increase in the prevalence. We're just seeing an increase in help seeking. Or it could mean that we are in fact having more and more cases of dementia, a higher incidence of dementia, right? You mentioned the pseudo dementia, which is to do with depression. We don't see that very often, but it's important to diagnose it because it's preventable, right? But the vascular dementia, now what we're seeing is it's almost like a merge of vascular dementia and Alzheimer's, because the high prevalence of the lifestyle diseases, it's almost like you diagnose Alzheimer's, but the person does have hypertension and diabetes. Now, there's a way of distinguishing between the two, all right? There's a term that is used. It's called stepwise deterioration, and it refers to the way the illness progresses. It refers to the way the dementia progresses. In Alzheimer's disease, you get a steady, slow decline. The person sometimes doesn't even recognize it at the beginning. The relatives will recognize it. So you find that the inability to find things, misplacing things, asking the same question over and over again, all of the evidence of a memory beginning to fail, the relatives might more be the one to say, hey, something really seems a little bit off here. This is not just normal aging, right? And then there is that steady but slow decline as time progresses. With a vascular dementia, however, we said before that is related to TIAs and to episodes of temporary blockage in the blood vessels to the brain. So you find that the person will experience a TIA. They may not remember it. They may not even be aware of it because it's transient. They don't pay it any mind. But the cognitive impairment develops. And they go along at that level for a while until the next TIA. And with that next TIA, the cognitive impairment worsens. So the cognitive function drops. And then they go along like that again on a plateau until the next TIA. And then the cognitive function drops again. So we call it a stepwise deterioration. You get a decline in the cognitive function every time you get that vascular incident. And that is one of the differentiating factors between the Alzheimer's and the vascular dementia, right? But as I said, now we're seeing vascular dementia merging into the steady progression of the Alzheimer's. So just overall, dementia is increasing.
Interesting, very insightful indeed. A couple more questions from our audience, listeners that I want to get in here. Somebody is asking here, is there, you may have referenced this before, but I'll still ask it. Is there anything we can do to delay these aging conditions?
Yeah, so we would have mentioned it before. Healthy lifestyle to reduce the risk of vascular dementia. Not much we can do to reduce the risk of Alzheimer's disease. And yeah, those are the two main ones. I want to make a pitch for sleep though. I want to make a pitch for sleep.
For sleep, wow.
Yes, sleep. There is a syndrome. Oh gosh, no, see my memory. That's age, eh? That's age. But but it's not a dementia. Minor cognitive impairment. That's it. Minor cognitive impairment, where persons have the short-term memory impairment, the decrease in focus, the decrease in concentration, and so right. And it happens to me. So it happens to me. And I've recognized that it happens to a lot of people. And you know what it's related to? It's related to stress and sleep, inadequate sleep. And I'm sure viewers can identify with this. If you go on a stretch of inadequate sleep, your memory is short. The short-term memory just does not work the way it should. But if you get a good night's sleep, thank God for the Sabbath. If you get a good night's sleep, when you get up feeling refreshed, not just physically, but cognitively. Now, sometimes our jobs, our professions, our careers lead us to sleep deprivation. And I confess that I am one of those where, unfortunately, this occurs. And it led me to do a lot of research about this minor cognitive impairment and whether it increases the risk for, let's say, Alzheimer's disease. I haven't gotten any answers for that yet. The research hasn't answered that question yet. But in terms of prevention of cognitive impairment in general, adequate sleep and social engagement, because studies are showing that if you don't have adequate social engagement, your risk of cognitive symptoms, now we're not here talking dementia, cognitive symptoms increases. So those are two things that we might want to do: adequate social engagement, adequate sleep, and keep your brain mentally stimulated. Again, the evidence, some people say yes, some people say no, but the value of doing things like crossword puzzles and Sudoku puzzles, and so you want to keep the brain stimulated, use it or you lose it kind of thing. All right. So those cognitive exercises are ones that we might want to engage in to make sure that we keep those neural pathways active.
Indeed, I can see that we're going to run out of time. That's whenever I have you on, we never have enough time.
Oh,
but so let's take another question from our viewers. I do want to give attention to what they are asking. Yes. This person says, Dr. Greene, I know of a relative practicing a strict vegetarian diet and still got a stroke. Yeah. How is that? No, that is not strange, but go ahead.
Yeah, no, it's not strange, because diet is not the only thing that increases the risk of lifestyle diseases. The healthier your diet, the lower your risk, but a healthy diet does not mean that you won't develop these diseases. So there are other risk factors, and you can get a stroke for other reasons.
Mm-hmm. Yeah, now the other question is, you said, some persons may be destined, and I think we're talking here genetics. There is a connection, there's a genetic connection, there may be, let me say, between, so if my mother had dementia, should that make me open my eyes to say there's a possibility that I may get it?
Yeah. Yes, the answer to the short answer to that is yes. Having a family history does increase risk, but it's not a must and will have it. So you can have a family history of Alzheimer's and not get it. And you can not have a history of Alzheimer's and get it, right? So the genetics does not weigh heavily with Alzheimer's disease. There is a particular type, a subtype of Alzheimer's called familial Alzheimer's. That is very strongly genetic. You have a 50% chance of developing that if a relative has it. But that's a very aggressive type of Alzheimer's that tends to develop very young, from in the late 40s and 50s. And we don't see that very often at all. That one is heavily genetic. But the Alzheimer's disease that we commonly see, there is a genetic contribution, but not overwhelmingly so. And again, the biggest risk factor is aging.
I think what some of our viewers want to know is, okay, here are two individuals, they're exposed to the same environment, they grew up in the same area. One person, is there something that says, hey, listen, we are all going to get old one of these days. So I practice good health. I try as best as possible to live the principles of New Start. And yet one person ends up with dementia, the other doesn't. Why?
Don't know.
Okay.
Don't know. They really, not that I don't know. It's not known.
Yes, I understand.
Right? Yeah, it's not known. It's not known. And why all of a sudden these brain cells break down, and there's a very distinctive pattern to Alzheimer's. You get these plaques in the brain and tangles and so on. Nobody knows why.
I wanted to ask you if you could talk a little bit more about Alzheimer's, since it's the one that is more prevalent in a number of cases. Okay. Just, some of the things. So if I'm managing somebody who has Alzheimer's, what do I need to know? What can you tell me that would help me to appreciate what I'm doing a little better? Okay, all right. So we said before that it's a progressive illness, all right? And in the early stages, it may not be very easily distinguished from the normal aging process, because with age, memory does become impaired. So you start with an impairment of short-term memory, and you misplace things, and you don't remember names, you don't remember dates, and so on. That can occur in normal aging. But when you notice that it is progressive, then or that it is more severe than one would expect for the individual's age, then you start to think about whether this might be an Alzheimer's. So you have the impairment of short-term memory. The person is actually slowing down in their thought. They start to use little prompts and cues. So reminder lists and, little writing down things more than usual and so on. That's how it starts. You begin concern now as it increases to the moderate kind of phase where there is an increasing confusion. The person actually becomes disoriented and their judgment becomes impaired. So they start doing things that are out of character, things that you would not really expect. And the memory loss is greater. Now, as this starts to advance, the memory loss is greater, but the individual does not usually have the insight that something is happening to me. My memory is failing. What happens instead is the personality begins to change and they become very accusatory. You stole my stuff. Somebody broke into the house and stole my stuff. So there's a lot of accusation now, almost like it's not a rationalization because it's not done consciously and deliberately, but it is the person's compensation for the memory loss that is taking place. For the relatives, this can be a very distressing experience. You probably have recognized that the person is ill, they have a dementia, because you've seen the deterioration, the steady decline in the memory. And now here you have these mood changes where they could become aggressive. We talked about the catastrophic reaction. They become suspicious because they are misplacing things, but they are blaming you. You have to be very patient. You have to recognize that this is
illness. And don't try to reason and explain to the person, but something is wrong with you. They're not going to be able to appreciate that. So you just have to try to make it easy for them. Have specific places for them to put things so that they know where to go to find it. Keep the routine simple and maintain the routine. Sometimes you find that there are individuals, they say, okay, you're under stress, I'm going to take you for a vacation. That's the worst thing you can do if someone has early dementia, because they are relying on their long-term memory and the layout of the home, for example, where the bathroom is, where the bedroom is in their long-term memory. And if you take them and put them in a new environment, you actually increase their disorientation. I saw a patient once who the relatives brought her, and she was diagnosed with Alzheimer's, dementia of the Alzheimer's type. And they recognized it when she came back from a cruise. And it was only in retrospect they were able to say, oh yes, maybe before the cruise it was there, but they never recognized it. But going on the cruise triggered that extreme disorientation because of the change in environment, and the illness was able to be diagnosed. So you want to be patient with your loved one. You want to not challenge them or engage them in trying to be better. You want to give them simple tasks to do as the illness deteriorates and they can't do very much. Then let them still feel useful and purposeful. Let them help you fold the clothes or do something like that. All right. But most of all, you want to help them compensate for their poor memory by keeping things organized, a steady routine, and keeping things in one place.
Well, Dr. Reed, I am so very grateful for the wealth of information you shared. There are lots more that we can talk about, but our time is up. And the young people do have another program around 4 o'clock, I think, a little after. It's up at 4 o'clock now, so it has to be a few minutes after. In fact, I was asked to remind our listeners that Truth Be Told this afternoon will take place immediately after we are done. And you want to bear that in mind. They are going to be talking about rebels and rules. All right, that's the young people's program. I want to also let you know, folks, that next week we begin a new series. We're going to be talking perspectives from young Adventist professionals, and we're going to be getting perspectives from young Adventist professionals from various parts around the world with respect to how they view the church, what they think the church should do differently, that kind of thing. Where are we as we move forward by the grace of God? We have been talking with Dr. Reed, Dr. Sanjay Reed, this afternoon. We are sorry we're out of time, but Dr. Reed, we so much appreciate. People have been asking questions, lots of questions that we don't have time to go into. We apologize for not being able to respond to all of the inquiries, but it was a delight sharing with you. I can tell you that the information you have presented has been so very meaningful. The comments in the chat already. There are lots of folks who have been asking. I'm going to ask you to take one more minute just to clarify this, because several persons have asked, can you say something about the association you spoke of with Soursop? Soursop was considered to be something that could be used to fight cancer, and so there are a few persons who are asking, did I hear you right? And so that we don't give any misunderstanding, you did give a lot of caution before you said what you said, and so that's why I'm asking you again, just to repeat, because some persons are saying, did I hear this right? Is that so? Is Soursop toxic, etc.? So yeah. All the way over time, I'm going to ask you to just respond to that one before we go.
Yes, and I appreciate that. I did wonder whether I should share it or not. But basically what I'm saying is that there is research taking place right now that suggests that in some persons, a minority of persons, the use of the Soursop leaf might be toxic to the brain. I do not think that we should use that information to discontinue the use of Soursop, because we also know that Soursop has benefits. It helps with sleep, the cancer fighting properties, as was mentioned, right? But We just want to be cautious in that we do not want to use it excessively. And I cannot define what excessively is because we don't have any guidelines for that yet. But we want to be cautious. And if you notice in any way that you might be developing any kind of cognitive difficulty, you might want to cut back on your use of Soursop leaf altogether. So I hope that clarifies.
Most certainly. Yes, it does. And I just wanted you to repeat it just for clarity.
Yes.
Because we don't want people leaving saying, things that we didn't say on this program. So we appreciate that. Again, thank you so much. Thank you so much. We really appreciate this. I wish I could talk with you for another hour on this subject, but they say that good things do come to an end. We appreciate you. One of these days, we will have you back with something else, we're sure. But may God be with you. And to all of our viewers and listeners, remember, we're going to be back here next week. Perspectives from Young Adventist Professionals. God bless. Until then.